difficulty. It's wonderful that so many of you could Zoom in tonight by computer, phone, or tablet to join me and our panelists for what I hope will be an opportunity as House members to hear directly from MDA trustees about issues the board is working on. I am also asking you to provide them with your valuable feedback on these issues, which will be addressed at our board meeting next week. Tonight offers a unique opportunity for us to meet using a relatively new technology involving some telecommunication. Communication is one of the 3 areas of focus I chose to concentrate efforts on this year. We are all so busy. It's difficult sometimes to be available at an in-person meeting. The distance is sometimes far, and we have other responsibilities. Zoom makes it possible for us to communicate from wherever we are, whether that is at our home, office, traveling, or really anywhere you have a reliable Wi-Fi. Zoom is currently being used for some committee meetings and work groups, and it's a great way to connect the board and the House. We can all meet together tonight without even having to leave our homes or offices. Wow. This gives you a chance to get to know the trustees and get information directly from them. It helps address any communication gaps, and it helps us to communicate much better. That's pretty exciting and helps our member dentists succeed with improved communication on issues being discussed at the House and the board level. There are so many possibilities to use this new technology for communication. So I thank you for participating with us tonight and spreading the word about how the MDA is working to make communication personal and easy. Tonight, we will talk about several issues directly from the board agenda for next week's meeting. We will be hearing from Dr. Todd Christy, the MDA Speaker of the House, Dr. Lisa Knowles, Dr. Vince Benivegna, Dr. Bill Patchak, and MDA Executive Director, Ms. Karen Burgess. At the end, we will have time for additional questions and feedback. However, you can ask a question or provide feedback at any time by clicking on the Q&A button on the bottom of your screen. There is also a chat button at the bottom of your screen. Use this feature to chat among yourselves or to comment if you are having a technical issue like not being able to hear. The panelists are not monitoring the chat, but staff will be and will try to help you resolve any technical issues. All right then, let's get started. We will begin with our MDA Speaker of the House, Dr. Todd Christy. Todd?
Good evening. It's my pleasure to be here with you tonight for our first Zoom conference to get out to the House of Delegates. And really, this came from one of the groups, one of the ideas that came from the MDA House of Delegates and Board Communications work group that you voted for last year. And so it's a unique opportunity. I'm excited that we're able to bring this to you as well. This function was one that came from them from our November meeting. So I have 2 topics to discuss with you tonight. The first one is, and again, from that same work group, is a request because as many people at the House of Delegates brought up both at the House and in their survey work, was that they didn't like the way the personal surveys that the board was doing to turn over what they've done over the previous year. And they felt that it was just putting information on a page, stock information. They really didn't, the House felt they weren't getting a good feel of what that trustee was doing or what they were thinking about when they were at the board. They wanted more information, a more personal touch, so they could get a better idea of how that trustee was doing. So what came from the work group was looking at questions, because in the past the questions were pretty much stock answers. I was at this meeting, this meeting, this meeting, this meeting, and how much more boring can you get? We can all read that information. So they developed 3 questions that you'll be seeing for the House this year coming from the trustees as to how they've developed the questions. So those 3 questions are, how can we strengthen our MDA governance system and its responsiveness to the membership? The second, what are your ideas for making sure the MDA is relevant to dentists in all practice settings? And 3, how can the MDA help local components do a better job engaging members? Now, a lot of times people might look and say, well, we need more specific answers. Well, the nice thing is you'll be able to get these answers and read the answers from your trustees and your executive committee as well. And you might get a different perspective on so many different topics. To try and tighten these down, the committee felt that if you made it too specific, you really put somebody in a box. But if you left it open, that way that answer could come out to them in many, many different ways, and you'd really get a flavor for the unique individuals that we have on our board and their perspectives. So I think that's what we're looking for from those. So that is one thing we have coming up. So let's move on to the next one. The next one that we have, let me pull up my screen here, is a resolution that's coming from one of our member dentists, Tom Goodsell, the delegate from Southwestern District. This one is, and the purpose of it is to alert the Michigan Dental Association in a timely manner of actions of a member dentist that could reflect on the member, the MDA, and the profession so that resolution can be achieved as quickly as possible. Well, what is this really? This is a policy on felony convictions. And this is where the challenge is that the resolution reads, and I will read this one, that any member of the Michigan Dental Association shall self-report felony convictions to the MDA Committee on Peer Review Ethics within 30 days of the final felony conviction, and that will update everything in the manual, the appropriate manuals that we have. Well, what are we looking at here? We know that a lot of times, and the only times that we get information on felony convictions is that when the felony is reported to the state board is if the state board takes action. And so this one allows and says that the member will not only self-report or be reported any felony conviction to the state board, but also self-report to the MDA peer review ethics. Within our bylaws, it has that any felony conviction has something that needs to be reviewed. But the challenge in the past was that there were felony convictions that were reported to the state board. The state board opted. They can choose whether to have anything and make hold anything against the dentist licensure or choose not to. So that's where the problem was, and that's why Dr. Goodsell wanted to bring this to us to take a look at. He feels that there may be some felonies that are reported that the state board doesn't take action on, that the MDA, it might have a reflection on the MDA, the member, and the profession. And so he'd like to have that be something that is evaluated. So we've been working on this one. Dr. Goodsell contacted me. We've been working on this one since the ADA meeting. And I believe that you want to take a look and read through this and see. And I think we'll have some good discussion at the House of Delegates on that. So, and also, so this will be coming up, and Dr. Goodsell will be at our meeting next week because he has some more specific cases that have come up. And I think that's what we'll get more at the board flavor. And I know he'll bring that to the House of Delegates for our April meeting. All right. I'm not seeing any questions and answers for me. That's good. So let's pass that on to Dr. Knowles next. Dr. Knowles.
Hi, good evening. I'm Lisa Knowles. I practice in East Lansing. This is my third year as a trustee, and I currently serve on the Finance Committee, and I'm also the liaison to the Peer Review, Care, and Well-Being Committee, which is actually what I'm going to talk about. One of my first topics is the Care and Well-Being Committee. It's been brought to our attention, we've kind of formulated as a committee that the Care and Well-Being Committee historically was a lot focused on substance abuse, alcoholism, drug abuse, and really a lot more it comes to mind when we start thinking of our overall health and well-being. So the committee is asking that the board consider a name change to expand that scope just a little bit to include issues like depression, anxiety, and stress-related illnesses. So we're requesting that the board actually change it to the Peer Review, Care, and Well-Being Committee. So not probably a lot of discussion on that, but just wanted to let everyone know that, you know, if there's issues, concerns, not just about alcoholism, substance abuse, but, you know, this is a committee to talk about, and we're going to be more visible and be really helping member dentists with stress levels, anxiety, depression, and things like that, that we think we can serve the membership much better and just be a good resource and a place to help more members. So that's my first topic. My second topic is about how we do reviews for applications for leadership positions and appointments to outside boards like the Board of Michigan State Board, like the Blue Cross Blue Shield Board, like the Delta Dental Board. So we get asked to kind of bring a list together, and then we pass those lists on to these people who ask us, like, who might be great, you know, leaders in their organizations. So it routinely in the past, this has been done internally at first, and the staff of the MDA does a whole internal review of the applicants, but it kind of came to our executive director, Karen Burgess's attention that really we weren't informing members that this was going to happen, that they would have a peer review process too, that all of their peer review confidentiality type of situations would be reviewed and looked at if you decide to apply for a position within the MDA. So Karen suggested that the Committee on Peer Review and Dental Care and Committee on Peer Review Ethics take a look at and update their manuals, which they did. They met in January, and they basically came up with some recommendations for the board and for all of us and I'm just going to read this, kind of boring, but I'm just going to read that, that the staff will continue to conduct the internal reviews at the direction of the committee. The review will consist of all peer review, both actions and compliance, state board actions, and interpersonal and communication relationships with the MDA staff, components, and state committee. Secondly, if the staff determines that a review is questionable, the chair will appoint a subcommittee to review and discuss all factors involved to include peer review, both actions and compliance, state board actions, and interpersonal communications with the MDA staff, components, and state committee. Third, due to confidentiality, if the subcommittee believes that an applicant should not move forward, it will inform the appropriate staff and or committee only that they do not believe that the applicant should move forward. And last, the subcommittee will report its findings to the parent committee at its next meeting. So basically, this is just to make anybody who applies for these leadership positions or appointments aware that your peer, you will be going through your peer review documentation, anything you ever went through with the MDA will be considered as a factor if you apply. So pretty straightforward, but just kind of want everybody to know, and you might not think about that when you do go through peer review because you think, oh, that's confidential. No one will ever, that's not supposed to be used against me, so to speak. But we think that's really important as a board, and I think as the MDA staff too agree that that's probably something that should be considered when you're being passed on to a leadership position. So that's all I have for this evening, and I'm going to pass it on to Dr. Vince Benivegna, who is next.
Well, hi, good evening. I'm Vince Benivegna, one of your trustees, coming to you from Okemos, Michigan. I also sit on the on Governor Schneider's Prescription Drug and Opioid Abuse Commission, and I'm in my second year of that currently, and that's what I'm charged with talking to you about tonight. A couple of things, but not exactly that commission, but there's a stakeholder group that's a similar kind of group of people that have gotten together to combat the opioid crisis in Michigan, and they call themselves the Health Professions Stakeholder Group. And that's made up of basically a lot of healthcare organizations like the Michigan Dental Association and their executive directors and their lobbyists that have been trying to influence what's happening with combating the opioid crisis in Michigan. Specifically, the members of the stakeholder group are the Michigan Academy of Family Medicine, Michigan Academy of Physicians Assistants, Michigan Chapter of American Academy of Pediatrics, Michigan College of Emergency Physicians, Michigan Council of Nurse Practitioners, Michigan Dental Association, Michigan Health and Hospital Association, Michigan Pharmacists Association, Michigan Psychiatric Society, Michigan Osteopathic Society, Michigan Society of Addiction Medicine, Michigan Society of Interventional Pain Physicians, and Michigan Veterinary Medical Association. So that's a lot of people that are kind of putting their heads together and collaborating and trying to influence the legislature and other things in Michigan, laws specifically that are being crafted to help combat the opioid crisis. And so the stakeholder group has been kind of going around and they've put together a joint 10-point plan to combat the opioid mortality crisis. And that plan, I was just at a meeting today of the Michigan Prescription Drug and Opioid Abuse Commission down in the Ottawa building in Lansing. And we had a presentation from the stakeholder group, and they've kind of distilled down the 10-point plan to kind of a 3-point plan now. So in a nutshell, the 3-point plan is to reduce the supply and demand for prescription opioids. Number 2, improve access to evidence-based pain management and addiction therapies. And number 3, reduce mortality rates. So those are their main goals. But the actual 10-point plan, number 1 is to develop and disseminate a clearly defined and actionable overreaching state-specific guideline through the Michigan Quality Improvement Consortium that incorporates the 2016 CDC pain guidelines. So these are guidelines that were crafted by the CDC in 2016, and basically our group is trying to get them implemented, and they're like best practices that we're trying to get the word out on, and actually to help guide our legislature in crafting their laws that will affect our ability to prescribe opioids for our patients. Number 1 also it encourages the use of MAPS and the newly released NextCare risk scoring tools. So that's pretty cool. If you haven't signed up for MAPS already, I would really encourage you to do that if you prescribe any opioids. MAPS is it's a database where you can look up your patients and see what opioids and also benzodiazepines and stimulants that they've been getting. And it also has a NextCare, it has a NARC score with it. And the cool thing about that is that will tell you what their risk for overdose is, actually, based upon their prescriptions that they've been given over the last 2 years. So it's a helpful tool when you're considering prescribing an opioid for a patient, especially if you suspect that maybe that they've gotten an opioid from another prescriber, or in their medical history, they say they're on a benzodiazepine like Valium or Xanax or Ativan, or any stimulants. Stimulants are becoming a big one now, and muscle relaxers like Flexeril, Robaxin, things like that. So, all right, so number 2 on the 10-point plan is to develop and teach a uniform core evidence-based opioid curriculum throughout professional schools, professional societies, hospitals, and health plans. So in the curriculum now of dental and medical schools, pharmacies, veterinary schools, there's going to be curriculum that's built around opioid prescribing, best practices, recognizing addiction, treating addiction, things like that. And not only in professional schools, but you're going to see it in your kids' schools. So you're going to see it very soon. Actually, this coming year, you're going to see it. It's mandatory that it's being taught in the high schools now, and so you're going to see it in your kids' health class and things like that. They're going to come home maybe with some questions for you and ask you about your prescribing possibly. Number 3 is to develop referral centers of excellence and telemedicine consultation call centers to assist providers manage complex pain and addiction cases. So basically, this is to help people get into treatment that need to get into treatment that have addiction issues. Number 4, leverage MAPS and NARC's risk index scores to drive point of care decisions. I kind of went over that already, encouraging you to get registered with MAPS. Number 5, develop a peer review process to assist providers who are outliers in prescribing behavior. So MAPS is kind of developed not to be punitive, but it's to be a helpful tool to help both the prescriber and the patient. And so MAPS data will be looked at, and if you're an outlier, if your prescribing habits are outside the normal scope of practice, you may have somebody give you a call or a letter saying, hey, you should consider this or that, or you're outside the guidelines here. And then if you don't respond to that and continue to prescribe outside of those guidelines, then you might have another letter from like some type of state peer review. Not necessarily with the MDA, but with LARA, for instance, in Michigan. Number 6, develop opioid related quality metrics that reward providers for delivering high quality standard of care. So what would that mean? Well, I had a meeting with Michelle Tulek-Gurecki and Bill Sullivan not too long ago with Blue Cross Blue Shield. And interestingly enough, they actually have some rewards for medical docs that are surgeons that do surgeries and then pledge not to use opioids post-operatively for pain management. And there's actually a modifier 22, that they can use, and they will get paid up to 30% more for their procedure. So I'm trying to get that for dentistry too, but I don't know if it's going to fly, but I guess we can work on it. Number 7, support managed care and pharmacy specific programs to control high doses and quantities of prescription opioids and require justification if they're required. Support number 8 is support community-based education programs to prevent inappropriate drug use in the first place and eliminate cultural mores that promote atypical drug behavior. Number 9, work closely with law enforcement to eliminate illicit drugs from our communities, fully noting that illicitly trafficked heroin and fentanyl analogs are now outpacing prescription opioid-related deaths in 2015 through 2017. And number 10, support efforts to improve surveillance and detention of opioid-related deaths, including improved toxicology screening for previously undetectable fentanyl analogs. So that's kind of what's going on now, is that fentanyl is becoming a pretty big issue for those people that kind of graduate from prescription opioids to heroin and fentanyl. Fentanyl, there's a lot of designer fentanyl out there that you can't pick up with a urine test, and you can't pick it up with certain toxicology tests. It's really hard to find. So that's one of the challenges now, is that we need they need some more tests out there to look at what people are taking, especially people that are in rehab, to make sure that they're being honest about what they're taking. So that's the 10-point plan. I have a question here. I guess I'll answer the questions at the end. And so then my second charge was to talk about the bona fide patient-provider relationship. So interestingly enough, in our February 2018 journal, which just hit my desk the other day, on page 6, this was put together by our legislative staff. Josh Kluzak's name's at the bottom of it, and I'm sure Bill Sullivan had a little bit to do with it as well. But in there, it talks about the state announces new regulations for prescribing controlled substances. Here's what you should know. And then they kind of go over all the laws that were recently signed into place in Michigan and when they take effect. So one of them is this bona fide patient-prescriber relationship. Beginning March 31st, 2018, so it's coming up pretty quick, a licensed prescriber must not prescribe a controlled substance listed in Schedules 2 through 5. So what's 2 through 5? So Schedule 2 is like hydrocodone, and then then there's 3, 4, and 5, which are less potent medications. I believe codeine is 3, and hydrocodone used to be 3, but then they bumped it up to 2. So basically, you cannot prescribe these substances unless the prescriber is in a bona fide prescriber-patient relationship with the patient for whom the controlled substance is being prescribed. So you can't just do this to any unknown person that comes to you off the street and asks you for a script. So this is defined, a bona fide prescriber is defined as, what this means is a bona fide prescriber-patient relationship means a treatment or counseling relationship between a prescriber and a patient in which both of the following are present. Number 1, the prescriber has reviewed the patient's relevant medical or clinical records and completed a full assessment of the patient's medical history and current medical conditions, including a relevant medical evaluation of the patient conducted in person or via telehealth. So you can do it over the phone, I guess. The prescriber has created and maintained, this is number 2, the prescriber has created and maintained records of the patient's condition in accordance with the medically accepted standards. The prescriber also must provide follow-up care to the patient to monitor the efficacy of the use of the controlled substance. If follow-up care is not possible, the provider should refer the patient to the patient's primary care provider for follow-up care, or if the patient does not have a primary care provider, he or she should refer the patient to another licensed prescriber who is geographically accessible to the patient for follow-up care. So basically, you just can't abandon the patient if you're unable to care for them and follow up with your prescriptions that you've given them, and you should find them another provider that will be willing to take them on. So that's what the bona fide patient-prescriber relationship is. That's something new that's going to be implemented in March of this year. So any questions? I see a question from Dr. Vitek. How would you suggest approaching a fellow medical colleague about their prescribing practices that you feel are inappropriate? Is there information about MAPS that we can print out as a flyer to give to fellow providers who might be unaware of the MAPS program that exists? So how would I suggest approaching a fellow medical colleague about prescribing practices? That's tough. It's really tough because I've been kind of lecturing on this and talking to my oral surgery colleagues about it, and a lot of them don't want to change their ways and insist that it's my patient provider relationship that you're interfering with here, and I'm going to continue to do what I've always done. So I try and open their eyes to statistics, and let them know how, what the risks are of continuing to prescribe opioids outside of the newer best practices guidelines that are out there, and the white papers that are out there that tell you how much and for how long you should prescribe. And actually now there's laws that are going to be in effect this year that will only allow you to prescribe for a 7-day or 3-day course of an opioid. And it talks about refills and things like that. And children, adolescents, things like that are all covered in these new laws that have been passed. So I would just bring up the statistics and let them know that it's very risky and that they're really endangering the lives of their patients, especially young patients, and they put them at risk long-term for addiction and abuse of opioids down the road. And that there's significant CDC statistics that back up what I'm saying. There's been a lot of articles in our own literature. I always like when I talk to people to kind of cite our own literature. So if I'm talking to dentists, I'll cite our dental literature. If I'm talking to ENT people, I'll cite the ENT literature. So there's been a lot of articles, and I can get them to you, Alexa, or show you where to find them, and that will support what I'm saying. So it's not just you or me that's saying what to do. The second question was about MAPS. MAPS is really easy to sign up for. You do have to, like anything these days, you have to create a username and password, and you have to put in some information regarding your DEA number and things like that. But once you do it, it's a very useful tool. It's not arduous to use at all. And you can get a lot of helpful information. I MAPS a lot of my patients now, not just the ones that I suspect have an opioid problem or that are drug seeking, but I try and do most of the patients that I prescribe opioids to, which is few and far between actually now. But you'll definitely be surprised at what you see, because a lot of patients will not tell you that they're on these medications in their medical history, when they list the meds that they're on. And certainly there's a lot of risky prescribing behavior out there that you may fall into unbeknownst to you, because they're on, like, let's say a benzodiazepine and a muscle relaxer already, and you're going to give them an opioid like hydrocodone or codeine, and that puts them at a much higher risk for addiction and overdose. So that's what we're doing. That's the 10-point plan. That's the bona fide provider relationship. And I think Alexa was my only question. So I'm finished with my part here, and I'm going to turn it over to Dr. Patchak. Thank you.
Good evening. My name's Bill Patchak, and I'm an orthodontist from Jackson, Michigan. I'm on my 5th year of being on the Board of Trustees, and I've been charged with this evening to discuss 2 different resolutions that we'll be discussing next week at our Board of Trustees meeting. The first is asking for support of a House bill. That's technically House Bill 5241. And what the bill is asking for is they want to add dental examinations onto an existing bill, which requires all children who are entering kindergarten to receive a vision test and a hearing test in the state of Michigan before they can enter kindergarten. And they would like to add dental exams onto this. It's I think it's kind of a no-brainer. I think it's real easy for that to happen, and everybody sits back and says, yes, let's support it. I think the big question that's going to be for the House is, or for the legislature, is how they're going to end up funding this. The current rule is written such that they're just going to turn it over to the health departments, and the health departments will have to pay for it. Well, that's all said and good as long as they're going to give the health departments more money to pay for it. So that one's kind of a no-brainer. Everybody will support certainly getting a dental exam for all children entering kindergarten. That's only a good thing. The second of the resolutions that we're going to have is our current Action Alert software program proved to be very difficult to use, and we couldn't get all the information out of it as people sent letters into their legislatures for particular things that the Dental Association wanted to have passed in our favor. So we're looking at a new piece of legislation. This new piece of, it's different than the old piece. We'll be able to get much more information from it, but unfortunately this one's going to cost us some money, and it's not a lot of money. It's only about $6,000 a year. And but it will cost us some money in order to participate in this, but we're going to get a lot more information out of it, and it's going to be much more user friendly for the membership. And that's about all I have to talk about, and I am going to turn it over to Karen Burgess at this time.
Thank you, Dr. Patchak. It's a pleasure to be with you. Everybody who's out there is participants. I'm going to be talking about our strategic plan. The MDA has a strategic plan that covers 4 years from 2016 to 2020. And it's really very much a living document. We have a strategic plan update at every meeting. As it turns out, at the February meeting is when we look at a lot of the metrics associated with our strategic plan. So it's an important time for updating the board on the progress. There are 4 goals to our strategic plan. The first 2 are membership goals. Membership goal 1 is to deliver exceptional membership value. The second goal is to increase member participation. Then we have a finance goal, which is to assure organizational sustainability. And finally, our organizational goal is that the MDA's capacity will be sufficient to meet the needs of our membership. So you can see that all the goals are really fairly broad goals. They're not goals that will need to be changed frequently, but under each goal comes a series of objectives. And those objectives tend to be things that can be measured very objectively, so that we can see, are we improving, are we making progress? And so let's talk just for a minute about the exceptional member value goal. The objectives underneath it are for the MDA to meet current and emerging dentist and dental team needs for continuing education. Why? Because that's such an important part of being a dental professional, right? And you turn to your organization for that continuing education. So that's our first objective. Our second objective is to help members succeed by providing practice management resources. That one speaks for itself as well. And then the third one is to favorably position the profession and MDA members with the legislature and the public. So you might ask, how are you going to measure those? Those seem very, qualitative. And how we measure it is through surveying the members to see, do they agree that the MDA is accomplishing those objectives? How many people strongly agree or agree versus how many people don't agree? So we did a survey in 2016, and the scores were really quite good. That set a baseline for all three of those objectives. And we will be very shortly conducting a follow-up survey that's very similar to the first one to measure those things as well, to see if we've had any upward movement or any downward movement, which of course you do not want downward movement. So that's how that metric is measured. And the board will be looking at the survey instrument next week to say, this looks good, or if they have an additional question or two that they would like us to ask while we're out there talking to the members. On membership goal 2, increasing member participation, now is a good time of the year to look at how our metrics are going. Member participation basically addresses how many members do we have. And we do it through looking at member retention and our overall numbers. Now in this area, increasing member participation, of course we always want more active members and more total members. And we had very good metrics last year because we had tried a new approach to member recruitment at the end of the year. And we did something that was called a Just Say Yes campaign, because at the end of the year, eligible dentists can join for the last 3 months of the year at $0. So it's a very low barrier to entry. Well, this year we are suffering for that decision because although our numbers are higher than at the end of the year 2015, one of the things we found was that only 31% of those people who took advantage of that special deal actually stayed members. So that was a tough lesson for us to learn, but we're doing things differently now. So at this point in time, we're documenting the fact that in 2017, we only got 42 people to join at that rate, but they were people who really wanted to be members. So we're expecting to see a much better retention rate for that group. Another thing that's affecting our ability to grow our membership is the number of dentists in the baby boomer, which is my own, demographic. As more dentists are reaching a more mature stage, shall we say, in their career cycle, they are moving into active life category, retired life category. So as they are moving towards the end, it makes it more difficult for us to have larger numbers and replace them with people who are younger, who are paying full dues and who are active. So, increasing member participation, we have had some good metrics, but overall, I would say that we really need to refocus on that this year. Our finance goal relates to organizational sustainability, and as a result, we look at things like our budget. We want our budgeted revenue to exceed budgeted expense. That's something that we routinely budget for a slight being in the black. And what we are finding is that we're actually doing better in terms of revenue and keeping our expenses down. So generally speaking, and this year will be no difference, we're actually having a larger surplus than we budgeted for. We're also looking at increasing non-dues revenue, and that's an area where we're seeing a big win. For example, we've had steady increases in non-dues revenue 2015, 2016, and again in 2017. So that just shows the financial sustainability of your organization because people are choosing to interact with us and buy our products and services. This is both coming from MDA IFG, our insurance and financial group, products and services, and also from the things like annual session, other CE, and the publications, things like that, that all our members purchase from the Michigan Dental Association. In addition, in terms of financial metrics, we also look at how well we're doing in terms of our reserves and also our investment income. And really good news in terms of investment income, you all have experienced, I'm sure, in your own portfolios, and unless you're putting it in the mattress, of course, that investments are doing very well. That's been great for us as well here at the Michigan Dental Association. And we had also recently made a change in terms of our investment advisors. They're much more hands-on and much more better in terms of the fees that we have to pay to them. So all in all, that works very much to our advantage. And when it comes to our reserves, we've been running about between 80 and 85% total reserves. So what that means is that our the money we have in our reserve account is the equivalent of 80% or more of our annual operating budget. So that is not only what we need per policy, but also a little cushion, which is great. And in terms of our final organizational goal, capacity, that really comes down to objectives in two areas. One is member engagement. We want to make sure that we have the capacity to share information with our components, that our components have the ability to share information with us. So for what that means is to increase the use of our component dental societies, keeping track of their members and our members, our mutual members, on Aptify, which is the ADA database that we all use. We had originally had just 2 component societies actively using Aptify. Now we have 6. So, you know, for those of you who are in Detroit, Genesee, Lakeland Valley, Livingston, Oakland, or Washtenaw, you can be proud that your dental society is one of the ones that are actively using Aptify. And we are going to be holding a training session on March 16th for any dental society that wants to participate. So we hope to see some bigger numbers when we do this again next year. And then on the leadership side, we think it's very important that we are engaging our members and filling the membership pipeline. You all are probably aware of our LEAD program here at the MDA. We've been dramatically increasing the number of leadership training opportunities that are available, not just for you guys who are already volunteers, but for the general members who might want to become more involved in the future so that they feel like they're kind of exposed to it and having the opportunity to participate. So this is an area where we're really experiencing a lot of wins. You see Dr. Christy recently launched a series of videos out to the house, and those are being very well engaged. A lot of people are going and looking at those, Todd. So congrats on that. We also have seen all our communications about leadership, Delegate Digest, EDU, Fiscal Facts, all of those things are increasingly getting better open rates. In other words, more people are opening and reading them, and click-through rates are up. So those are all the kinds of metrics that we report on our strategic plan update. We also talk about a number of different new programs that are emerging that support some of these, and I'll just highlight a couple of them that are brand new. We are just now launching our job board. So the job board is not just for dentist positions, but for dental assistant, dental hygiene, office, front office staff, etc. And we just launched, soft launch, and already have 26 ads running on that job board. So we expect that that will be useful in terms of helping members succeed, and that it's an opportunity for non-dues revenue, so it'll help us with financial sustainability. Another dental team thing that is really going very, very well is our Certified Dental Business Professional program. It's a pay-as-you-go continuing education program for front office staff. And we actually have 60 people signed up for that program already. So just to give you an idea of the kinds of activities that actually support the objectives that result in good ratings from our members. So I will stop there because I could talk all day on this and you don't want me to. So thank you.
Thank you very much, Karen. I appreciate everybody's participation. We only had a few questions tonight, so I'm going to ask one more time. If anybody has any questions for specific trustees or just questions in general that they would like to ask, you can put them in the Q&A section, please. And you can also provide us with maybe some comments or feedback about maybe issues that are going on in your component society right now that you might like the board to address or you think that we need to know about that we don't. We welcome those as well. So I'll give you a few minutes to type in anything that you might have. And if we don't see any questions, then I will wish you all a wonderful good night and thank you for participating today. And we hope to hear some feedback, at least on how you enjoyed this presentation and whether you think it's worthwhile for us to do things like this in the future. Thank you very much, everybody, for your time and attention.
Good night.